welcome to The Code Tray, the podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EM PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
We have Robert Aguilar, PGY2 EM resident at Jackson Memorial Hospital, who will be presenting on the comparison of the incidence of recovery agitation with two different doses of ketamine and procedural sedation.
Just some background, procedural sedation and analgesia involves administering sedative or dissociative agents with or without the concomitant delivery of analgesic agents. It's a common procedure done in the emergency department, and it's necessary to induce a state that allows the patient to tolerate unpleasant procedures, such as reductions, abscess, drainage, etc., while maintaining cardiorespiratory function. So it's just really important to allow these patients to minimize pain and then allow them to tolerate things like femur reductions and those types. Ketamine is commonly used and is an effective agent for procedural sedation and analgesia due to its dissociative as well as analgesic properties. So our other medications like midazolam, propofol, etomidate, if you're doing cardioversion, don't have these analgesic properties, whereas ketamine does, which makes it a little more beneficial compared to these other agents. Just some quick PK/PD on ketamine. It's a non-competitive NMDA receptor antagonist, so it inhibits glutamate, and its dose is in procedural sedation specifically is around 0.5 to 1 mg per kg. Rapid onset around 30 to 60 seconds. Duration, we typically get up to 15 minutes in these procedures before we either have to redose or use a different agent. As far as adverse effects, we can see laryngospasm, hypertension, hypotension, tachycardia, increased oral secretions, as well as emergence reactions. Part of its mechanism is it also causes catecholamine release, which is why we see a lot of hypertension as well as tachycardia in our patients. As far as previous literature, there's no real literature looking specifically at emergence reaction or agitation. However, it's something that's always looked at whenever studies are looking at ketamine. So in Dillip and colleagues, these were trauma patients greater than 16 years of age, requiring wound wash, suturing of a wound, screw fixation, closed reduction. They had 151 patients. For their intervention, they used a mean dose of 0.8 mg per kg to 1 mg per kg of ketamine. And what they found was that the incidence of adverse reactions was actually higher in younger patients, around 18 to 40 years old. And specifically for emergence delirium, they only saw it in actually 6 patients. So 6.9% of patients had emergence delirium. In Newton and colleagues, this was a prospective observational study in patients also greater than 16 years of age who received ketamine for procedural sedation. They used 0.5 to 1 mg per kg of ketamine. And what they found was 12% or 13% or 12 patients total developed recovery agitation. They also found that in this dosing range, adequate sedation was obtained in 99% of patients. So most patients did have adequate sedation. In Lamont and colleagues, these were adult patients greater than 18, presenting with an orthopedic injury and needing a procedural sedation. They had 153 patients. This was a multi-center randomized double-blind trial. And in this one, they compared ketamine 1 mg per kg versus ketofol, so ketamine 0.5 mg per kg and propofol 0.5 mg per kg. And what they actually found in their study was that significantly less recovery reactions were found with ketofol or ketamine and propofol when compared to ketamine. So it's 22.3% of patients had recovery agitation or emergence reaction versus 44.7% in the ketamine alone group, which is actually pretty high compared to the other trials. But of note in this trial, 22% of the patients in the ketamine propofol group actually required additional doses of ketamine and propofol compared to only 9.2% in the ketamine alone group. So with that background, now I'll be going into the trial that I looked at specifically, looking at low versus high dose ketamine. So as far as trial design, it was a single center prospective randomized single blinded trial conducted in Turkey. It was done at a tertiary training and research hospital between January and September of 2023. For the inclusion and exclusion criteria, they included patients 18 to 75 years of age who required procedural sedation and analgesia. They assessed 140 patients. They excluded 32, whether it be age, heart failure, COPD, alcohol intake. They ended up including 108 patients, 54 to the low dose and 54 to the high dose. For exclusion, they excluded pregnant patients, any history of liver or kidney transplant, liver failure or renal dysfunction, altered mental status, active coronary artery disease, any conditions that would affect consciousness, COPD, any unstable patient essentially, as well as patients with heart failure. For intervention for the low dose ketamine, it was 0.5 mg per kg, and for the high dose ketamine, it was 1 mg per kg. And they assessed based off of RAS score. So patients were determined to be adequately sedated if they had a RAS of at least -4. If it was greater than -4, then they determined it was insufficient sedation. And so they would give an additional half dose of what the initial dose was. So in the 0.5 mg per kg, if they weren't sufficiently sedated, they give an additional 0.25 mg per kg. And in the 1 mg per kg, they give an additional 0.5 mg per kg. And then before the procedure, they monitored vital signs, so blood pressure, heart rate, respiratory rate, temperature, oxygen saturation, measured all of those before as well as during. And any patients who failed to reach RAS score of -4 with an additional dose was excluded from the trial. As far as primary outcome, it was the incidence of recovery agitation, which was evaluated by RAS scores at time interval 5, 15, as well as 30 minutes after the procedure. For secondary outcomes, they assessed the efficacy of ketamine doses, so adequate sedation, as well as frequency of adverse effects other than recovery agitation. For statistical analysis, so based on previous studies, they assumed recovery agitation in the high-dose ketamine group would be around 25%. So they conducted a chi-square with a two-sided hypothesis in order to detect a 20% difference between the groups. And what they found was that a sample size of at least 49 patients per group would be required. And in order to account for what they thought would be a 10% dropout rate, they aimed to enroll 108 patients. For continuous variables, they used means and standard deviations or medians and interquartile ranges. And they did students' t-tests for normally distributed variables and Mann-Whitney U-tests for non-parametric data with the continuous variables. For categorical variables, they use chi-squared or Fisher's exact tests reported as numbers and frequencies. As far as baseline characteristics, they're pretty similar amongst groups. For age, both groups were around 50 years of age, mostly male patients. Weight was also similar, around 80 kilograms. As far as procedures, mostly reductions, abscess, incisions. There were some central catheter placements, chest tube placements. And then there is another 13% in the low dose and 22% in the high dose that they didn't specify what these procedures were. They just categorized them as other. As far as results, so RAS scores at time interval 5, 15, and 30 minutes were not statistically significant, so they're very similar between both groups, -4 in both the high and the low dose, -1 at 15 minutes in the low and the high dose, and 0 at 30 minutes in the low and the high dose. Their primary outcome of recovery agitation was also not significant between both groups, so 11 patients or 20% in the low dose, 12 patients or 22% in the high dose. And of note, recovery agitation was defined as a RAS score of greater than or equal to 2. So, and then clinically important recovery agitation, low dose ketamine, 1 patient, high dose ketamine, there were no patients. Again, this wasn't statistically significant because there's only 1 patient in both groups who actually had clinically important recovery agitation, which they defined as a RAS of 4. As far as overall sedation time in the low dose, it was actually higher than the high dose, so 21.5 minutes. High dose was 20 minutes. And then patients requiring additional ketamine, not really surprising. There were 4 patients who needed more ketamine in the low dose and none in the high dose ketamine. So overall, none of these were statistically significant, and there wasn't a huge difference between the low dose and the high dose. For RAS scores at 5, 15, and 30 minutes, At 5 minutes, there were 2 patients in each group who were found to be agitated and 2 patients who were restless in the low dose group. So again, no difference. For RASS scores at 15 minutes, more patients in the high dose were agitated with a RASS score of 2. But again, there wasn't a difference between that and the low dose group, with 6 in the low dose versus 9 in the high dose group. And then at 15 minutes, 2 patients were restless or had a RASS score of 1 in the high dose, and only 1 patient in the low dose. So very small amount of patients who are actually agitated or restless with RASS scores of 2 or 1 at all time intervals, essentially. And there's 1 patient who had a RASS score of 4 at 15 minutes in the low dose group, not in the high dose group. And at 30 minutes, there were 3 patients in the low dose group and 1 in the high dose who had a RASS of 1, and 2 in the low dose and 1 in the high dose who had a RASS score of 2. So really, overall, there was not a huge difference in RASS scores at these time intervals, and really not surprising again. As far as safety outcomes, the most common adverse effect was hypertension. As I mentioned, we do get some sympathomimetic activity just because ketamine has some catecholamine release. So hypertension, tachycardia was seen, hypotension in 1 patient. No patients had laryngospasm. 1 patient in the low dose had oxygen desaturation. There was no apnea. Nausea and vomiting, similar between both groups, 5 in the low dose and 6 in the high dose, so around 10% in both. Nystagmus, diplopia was the same in both groups, 18.5%, or 10 patients in both groups. So as far as the author's conclusion, they found that 0.5 mg per kg of IV ketamine may be considered a suitable starting dose for procedural sedation and analgesia, avoiding the need for potential higher doses of ketamine. As far as strengths and limitations, it was adequately powered to detect a 20% difference. Objective agitation metric with RASS, it's commonly used, and it was repeatedly measured at time intervals 5, 15, and 30 minutes. It was a randomized prospective study with pre-specified outcomes. For limitations, it was single-center design. It only included adult patients. So I know a lot of EDs, like our ED, we see pediatric patients. So that's a limitation. Lack of a universally accepted definition for recovery agitation. There isn't really something that defines recovery agitation. And then it was also single-blinded to only patients. So applicability in practice, I think it's reasonable to start ketamine at 0.5 mg per kg, as this trial found comparable recovery agitation, recovery time, as well as safety to 1 mg per kg, supporting lower initial dosing without loss of effectiveness. So realistically, I think whenever we're doing procedural sedation, it's really patient specific and not really a one size fits all. So I think starting with a lower dose is always appropriately, waiting for the drug to kick in and then assessing whether or not the patient needs more. So I think that this study really supported that. Here are my references. Are there any questions?
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.